Hola, welcome to the podcast series, The Memory Keepers. My name is Sylvia Bernaza. My pronouns are she, her, hers, y en español, soy ella. I am a doctoral candidate in the School of Social Work and a resident of Massachusetts. This podcast targets social workers and healthcare providers involved in the systems of care of Latinx caregivers of patients with Alzheimer's disease and other related dementias, ADRD. The core subject of the podcast is to highlight the realities that Latinx caregivers of ADRD patients face while navigating the healthcare system and the disparities that affect their well-being. 10 episodes will provide actual information about ADRD disease, the impact on the Latinx population residing in the United States. The episodes will address, among others, systemic responses to an issue that, according to different scholars, has taken epidemic proportions. It also includes the expectations and challenges caregivers face with access to services, the stigma suffered due to the population's intersecting characteristics, the cultural values, the relevance of the language, socioeconomic impact, the existing support, and what the caregiver needs. This podcast was created solely for educational purposes. The developer aims to promote changes that will increase social justice for the Latinx population who has been historically discriminated against. The podcast includes the participation of experts who will help the audience enhance their knowledge about the experience that Latinx caregivers of patients with ADRD face, along with actual caregivers and their suggestions to close the gap among existing services. On each episode, a recap of prior information will be summarized, along with an introduction of the guest speakers who are present and the subject for the day. The podcast will also include parts of testimonies of current caregivers and a nurse practitioner overseeing the implementation of services. The beauty and benefits of technology allow us to get closer and to share information, decreasing barriers such as distance, language, and financial factors. The series of episodes is designed to reach an audience interested in utilizing this opportunity to enhance knowledge in their own space and capacity. It requires access to the internet and a device with audio. This podcast is free of charge and does not require a subscription. It will be hosted through the YouTube platform. Completing the series will grant participants a certificate in cultural awareness among the Latinx population facing ADRD challenges. And with this, I would like to introduce the land of acknowledgement. I would like to begin by acknowledging that I am located on the traditional land of the Massachusetts people and recognize Massachusetts as past, present, and future stewards of this land. Today, there are 2 federally recognized tribes in Massachusetts, the Mashpee Wampanoag tribe and the Wampanoag tribe of Capehead. We must acknowledge these tribes, their elders, past, and present, and future generations. As a respectful and transformational and devoted social worker residing and servicing communities in Massachusetts, this land of acknowledgement is a way for me to recognize the history that has brought me to reside on the land. It is also a way to counter the narratives that this land was undiscovered when colonists arrived. I hope this lot of acknowledgement begins the process of better understanding the history of the land we are on and builds a more healthy and inclusive community. As an intentional social worker with the conviction to continue advancing adherence practices, I am sharing my positionality statement as a step towards embracing our diversity that has identifying ways to increase inclusion, acceptance, and respect among humanity. I am a Black cisgender woman who immigrated to this country 25 years ago. I embody multiple intersecting identities that impact how I navigate and make meaning of the world. My experiences as a daughter, sister, mother, and wife in the context of my family, culture, and racial background shape my perspectives. My multiple identities intersect to form positionality. I have an evolving consciousness around the privilege and oppression dynamics that impact me and the communities I serve. I know there are always new perspectives to seek, and that my self-work must continue if I am to show up fully for others. The creation of the podcast has personal, professional, and sentimental value as my mother's caregiver. Beautiful, strong, intelligent entrepreneur and loving woman who cares for others early and throughout her life. I, along with my sister, have suffered the struggles that ADRD represents for the Latinx population, from receiving the diagnosis, processing, and experiencing different feelings and emotions, to a transformative way of seeing life, inspired by the love for our mother and all the people who, like us, face the enormous responsibility of becoming their loved ones' memory keepers. This podcast was created to raise awareness among social workers and allies within the healthcare system about the increasing number of people diagnosed with ADRD, particularly among the Latinx population residing in the United States. The existing systems of care that promotes disparities among the neediest will be addressed, as well as the present practices that hinder their access to and benefits from services. As a member of the Latinx population, an immigrant, and a BIPOC, I have experienced firsthand the need to address the gap that separates the patients and the caregivers from the quality of services that will provide the support needed to continue working for a loved one, which health and cognitive capacities significantly decline along with the imminent disease progress. Understanding ADRD. With the introduction covered, let's dive into the content of our first episode. What are Alzheimer's disease and other related dementias? What is the impact on the Latin population residing in the United States? Dementia is one of the most expensive old age conditions and the most time-consuming for a family. The diagnostic term dementia has become widely used, and it is crucial to understand what it entails. So what is it? The terms dementia and Alzheimer's has been around for more than a century, which means people have likely been mixing them for that long too. Nevertheless, knowing the difference is important. Dementia is a generic term to describe a group of chronic, progressive, degenerative cognitive disorders that lead to a loss of independent functioning, resulting in a wide-ranging impact on individuals, families, and healthcare systems. Although about 100 different types of dementia exist, Alzheimer's disease accounts for more than 60% occult dementia in the population aged 65 and older. In simple terms, dementia is a group of symptoms that progress over time. People with dementia have problems with thinking, memory, and reasoning, and lose the ability to carry out tasks of daily living. They might also experience changes in personality, mood, and behavior. Alright, dementia comprises a large number of variants, and Alzheimer's was identified as one of those forms of dementias that are most commonly diagnosed. However, what is Alzheimer's, and what is the difference between the two diagnoses? Alzheimer's disease refers to the pathological and morphological changes in the hippocampus and other areas of the cortex responsible for language, reasoning, and behavior change that characterize the progression of the disease. Significant clinical symptoms of Alzheimer's disease include memory loss and multiple cognitive deficits. Studies also indicate that Alzheimer's disease is a cognitive impairment that many times is accompanied by mood and behavioral symptoms. Some of these behavioral symptoms include depression, anxiety, irritability, sleep disturbances, and agitation. Alzheimer's is the sixth leading cause of death in the United States and the fifth leading cause of death among Americans aged 65 and older. Patients suffering from Alzheimer's become dependent on others for their daily activities. The disease is characterized by a progressive decline in two or more cognitive domains, including memory, language, personality, and behaviors, which leads to an inability to perform basic activities of daily living. There is lots of information to help us understand and move forward using the terms with responsibility, as it affects many people's lives worldwide. However, I'm still curious about how ADRD was discovered. Let's share a little bit of history behind it. Alzheimer's disease is named after Dr. Alois Alzheimer. In 1906, Dr. Alzheimer noticed changes in the brain tissue of a 51-year-old woman who had died of an unusual mental illness. Her symptoms include memory loss, language problems, and unpredictable behavior. After she died, he examined her brain and found many abnormal clumps and bundles of fiber. Those plaques and tangles in the brain are still considered some of the main features of Alzheimer's. Another feature is the loss of connections between neurons in the brain. Neurons transmit messages between different parts of the brain and from the brain to muscles and organs in the body. In simplest terms, the difference between dementia and Alzheimer's is that one is broader than the other. If the two were nesting dolls, Alzheimer's will fit inside dementia, but not the other way around. While Alzheimer's disease is the most common form of dementia, accounting for an estimate of 60 to 80% of cases. In a study conducted by Llano and other scholars in 2016, it was concluded that dementia could be linked to a philosophical death as opposed to a biological death. Forgetting personal life history and difficulty retaining even fragmentary reminiscence of life could result in great pain to those who share a collective memory of the past. This is a beautiful tribute to the millions of people affected by the disease and to their caregivers' commitment and support. How ADRD looks like and who is affected the most. Alzheimer's disease and other related dementias are the subject of multiple studies, with the hope of finding ways to promote early diagnosis, slow the process, and hopefully shortly find a cure for a disease that is the 5th leading cause of death in the United States. Unpacking information about ADRD and the impact on the population of interest could take us more than one episode. The information is extended and valuable. Let's explore the details of how symptoms lead to the diagnosis. The Mayo and Johns Hopkins organizations agreed on indicating that the early signs of Alzheimer's disease might not be evident to anyone except the person with the disease and the people closest to them. Even then, the symptoms might be confused with normal changes that come with age. The National Institute of Health indicates that to make a diagnosis, healthcare providers usually interview the patient using several types of tests to determine how well the person's brain is working. These are often memory tests. They might seem like puzzles or word games. The healthcare providers might also take a health history and order some tests to check for other possible causes of memory loss and confusion. These tests might include brain scans like CT, MRI, or PET scans. The providers enhance their assessment through conversations with family members about symptoms and changes that they have noticed. Therefore, the importance of regular medical checkups, reporting different symptoms, advocating for early diagnosis, and the participation of the family members. The diagnostic criteria for Alzheimer type dementia, according to the American Psychiatric Association, goes as follows. A. Multiple cognitive deficits in both memory and one or more of the following. Aphasia, that is a disorder that damages portions of the brain responsible for the language. It usually occurs suddenly, often following a stroke or head injury, but it might also develop slowly due to brain tumors or progressive neurological diseases. Aphasia impairs the expression and understanding of language, as well as reading and writing. It can co-occur with speech disorders like dysarthria or apraxia of speech. Apraxia is a motor disorder caused by brain damage, specifically affecting the posterior parietal cortex of corpus callosum. It leads to difficulty performing daily tasks, even if the instructions are understood. People with apraxia might struggle with movements such as tying the shoelaces, buttoning shirts, or making certain facial expressions. There are different types of apraxia, including conceptual, ideational, buccofacial, and constructional. The third one is agnosia. The Cleveland Clinic defines agnosia as the inability to process sensory information. It results in a loss of ability to recognize familiar objects, persons, sounds, shapes, or smells, even though the specific sense is not affected. Agnosia can affect vision, hearing, smell, taste, and touch, basically all the senses. Another part to complete the diagnosis includes the executive functions. This refers to cognitive processes and mental skills that help individuals plan, monitor, and successfully execute their goals. These functions include attentional control, working memory, imitation, and problem solving. There are those who originate in the brain's prefrontal cortex. Disruption in executive function can impact success in various aspects of life, such as school, work, or daily tasks. All these areas that we have been identified are paired with impairment in social or occupational functions that represents a decline from previous levels. It also a gradual onset and continued cognitive decline, and also a deficit that is not due to other causes. All this comprises the diagnostic criteria so a patient can receive the diagnosis of Alzheimer's, dementia, or any of the dementias included under the umbrella of this diagnosis. The National Institute of Health indicates that Alzheimer's disease encompasses different stages that affect the patient differently. Therefore, the caregivers carry demands increase according to the disease and the patient's levels of functionality. The organization also said that research showed that patients receive a formal diagnosis after symptoms have become evident to others, and that a person can carry the disease 20 years before becoming formally diagnosed. The Mayo Clinic indicated in one of their articles that the rate of progression of Alzheimer's disease varies widely. On average, people with Alzheimer's disease live between 3 and 11 years after diagnosis. But some cases have been reported that people can live up to 20 or more years. The Johns Hopkins Institute in their report addressed the stages of ADRD, indicating that it usually follows a progressive pattern. However, each person moves through the disease stages in their own way. Knowing these stages helps healthcare providers and family members make decisions about how to care for someone who has Alzheimer's disease. This is a disease that is very mysterious, that has a very particular way to manifest, and there is not a written rule that is going to be placing people on periods of time. Each patient is going to be developing the disease and is going to be going through on their own particular and unique pace. However, let's talk a little bit about the stages so we can understand how patients are going to be presenting according to the progressive characteristic of the disease. The first one is the preclinical stage. Changes in the brain begin years before a person shows any signs of the disease. This period is called preclinical Alzheimer's disease, and it can last for years. The second part is the mild and early stage. Symptoms at this stage include mild forgetfulness. This might seems like the mild forgetfulness that often comes along with aging. However, it might also include problems with concentration. A person might still live independently at this stage, but might have problems with remembering a name, recalling recent events, remembering where he or she put a valuable object, making plans, staying organized, managing money. The person may be aware of memory lapses, and their friends, families, or neighbors might also notice some difficulties. Then is the moderate middle stage. This is typically the longest stage, usually lasting many years. At this stage, symptoms include increasing trouble remembering events, problems learning new things, trouble with planning complicated events like a dinner, trouble remembering their own name, but not details about their own life, such as addresses and phone numbers, problems with reading, writing, and working with numbers. As the disease progresses, the person might note that some people are familiar with, but do not remember their names or forget the names of the spouse or the child, lose track of time and place, need help choosing the right clothing, getting dressed, and with daily activities such as brushing their teeth, become moody or withdrawn, or have personality changes such as hallucinations, paranoias, or delusions. Be restless, agitated, anxious, or tearful, especially in the late afternoon or at night. Physical changes might occur as well. So people have sleep problems, and wandering away from home is often a safety concern. The third stage is the severe or the late stage. At this stage, a person loses many physical abilities including walking, sitting, and eating, may lose bowel and bladder control, may be unable to say some words or phrases, but not have a full conversation, need help with all activities at all times, isn't aware of recent experiences of his own or her surroundings, is more likely to get infections, especially pneumonia. As the disease progresses, the caregiver demands also place significant pressure on caregivers and the requirements for effective responses from the systems of care by acknowledging that minorities, including the Latino population, presents with intersecting factors that increase their vulnerability. The Alzheimer's Association, along with researchers and scholars on the subject, indicate that until the present time, there has not been found concrete reasons for the disease to appear, rather than a combination of multiple factors such as genetic, environmental, and diet, among others. They also indicate no cure. However, in 2023, the Federal Drug Administration approved and introduced a blood test that was found to have an advanced accuracy determining the possibility of people developing the disease 10 years in advance. The medical doctors indicated that although there is no clear preventable part, it is recommended to review lifestyle mindfully, choose diet wisely, include exercise, and have regular medical checkups. The social implications of ADRD within the Latinx community, exploring how affect individuals, families, and caregivers. The ADRD presents with its own set of challenges that start by not knowing the exact causes of it, the disproportionate way in which minorities are affected, and existing treatments that, although they have been found helpful in somehow containing the disease, are not a guarantee of controlling the progress or decreasing pace of cognitive and physical declines in patients. According to different studies among Latinx caregivers of patients with ADRD, not knowing the nuances of the disease and not understanding the early symptoms presenting in patients are some of the most challenging aspects of caring for a loved one. This podcast aims to call attention of providers, policymakers, social workers, and all allies to the impact of ADRD on the population and the implicit systems of discriminations that place Latinx people in positions of disadvantage concerning others. Impact of ADRD on the Latinx population. A significant body of literature addresses the impact of ADRD on the Latinx population. However, the research about this particular group became more prominent in the late 90s and early 2000s. Some of the researchers and scholars indicate, for instance, according to the Alzheimer's Association, approximately 13% of Hispanics aged 65 or over live with Alzheimer's disease and other forms of dementing illnesses. Much evidence suggests that remarkable differences exist in the prevalence, incidence, mortality, and treatment of Alzheimer's disease among ethnic and racial groups in the U.S. The Hispanic population has increased by approximately 3 times since 2000. Research on racial and ethnic minorities in nursing homes found that between 1998 and 2008, the number of elderly non-white Hispanic individuals living in nursing homes increased by 54.9% due to a rapid growth in the older minority population. Latinx people face a lack of educational outreach, financial status, less access to medical facilities, linguistic barriers, and food habits. The caregiver burden faced by this community is a significant issue in ADRD clinical research. The Latinx population is a high risk of developing ADRD, and therefore their disease often progresses to require caregivers who are the ones facing the disparities in accessing existing services. Latinos have a higher burden of disease and greater poverty, coupled with less utilization of services. Latinos also appear to have higher rates related to ADRD compared to the counterpart whites. The 2020 census also indicates that the makeup of the population has become more diverse than in prior years. Among those, the Latinx population is identified as the fastest growing minority in the United States. Valle and other scholars in 2004 indicate that the Latinx people present with a higher percentage of diagnosis with ADHD due to intersecting factors such as poverty, limited literacy, underlying medical conditions, and late diagnosis, among other factors. These characteristics, coupled with existing policies and regulations within the healthcare system, hinder the direct access to the existing services. Therefore, ADRD patients rely on the care of their family and friends for direct care. The information presented invited to reflect about access to services, if any, in rural areas, in which travel distances, limited linguistically appropriate services, limited access to specialists can directly affect the population in need. More than 65 million Americans living in rural areas are above the age of 50. Older people from rural areas are more likely to reside among, below or near the poverty line, and suffer from chronic diseases. An estimate of 51% of caregivers in rural areas use population-based services. Due to this overburden of ADRD and the lack of medical facilities, the number of informal caregivers will gradually increase. A 2021 study by Martinez and other scholars highlights that the Latino population in the United States is increasing in size and diversity, doubling from approximately 49 million in 2009 to 106 million by 2050. Therefore, the U.S. Latino population aged 65 and older will increase from 8% to 22% by 2060. They also were found to have a life expectancy of 87 years old. To increase the accountability of services and the accuracy of the data collected, it is crucial to respectfully meet the patients and their families, ensuring a response that pairs their cultural and linguistical capacities. However, there are some limitations that are based on the linguistic capacity, on the scholar and knowledge that patients and caregivers have, and also in the trust on the system. Older Hispanic individuals are a racially and ethnically heterogeneous group of people with widely different origins, migration history, cultural and traditional beliefs, economics and psychosocial status, language proficiency, and levels of acculturation to the dominant culture. This minoritized group of people requires assistance navigating the healthcare system, advocating for culturally and linguistically crafted programs that promote their inclusion and embrace the diversity by incorporating the voices from a perspective of intentionally increasing equitable access to services. Knowing the health literacy of an elder patient and their caregiver is necessary because caregivers assist patients in different tasks, manage daily health care, administer medication, and make health services utilization decisions. According to the World Health Organization, health leadership is the cognitive and social skills that determines people's ability to gain access, understand, and use knowledge in ways that promote and maintain good health. The subject has been widely addressed due to the increasing diagnosis and subsequently incurring demands that are spontaneously provided by family members and older friends of the patients. Multiple studies indicate that caregivers do not have the option to choose if they would like to care or not, but rather to take the lead in ensuring the care and the well-being of their loved ones. People experience the changes on their families when their friends become worried, become concerned, and on many occasions, the diagnosis is delayed, waiting for someone to become available to go with the patient and seek the medical care. Once the information is received, it opens up a totally different dynamics in which the caregiver becomes the memory keeper of the patient, a person that no longer can advocate for themselves. A study published by the Oxford University Press on behalf of the Gerontological Society of America in 2021 indicates that the number of Latinos living with Alzheimer's disease is projected to grow by 832%, and that the disease will cost Latinos families $2.3 trillion by 2060. The literature review reveals that the Latinx population was included in the ADRD research in the late 90s. Until then, Latinx patients of ADRD were left with inconclusive, delayed, or inaccurate diagnosis for the symptoms of cognitive decline and memory loss. In their article, Martinez and other scholars on 2020 indicated that Latinx families delay seeking medical support due to their own bias towards the system, fear of discrimination, limited literacy about the disease, and their understanding of this as an older people disease. However, the National Institute of Health indicates that more people have been diagnosed at early ages, creating concerns due to the absence of early diagnosis, tests, preventable services, or cure for the disease. The observed rise of ADRD among the Latinx group in the U.S. and its related challenges can be partly attributed to the gaps in healthcare services and access to care. Identifying culturally competent staff who speak the language necessary to communicate with the patient is a major challenge among minorities seeking access to adequate care. And this makes me reflect about the many differences among people that speak Spanish. The Latinx populations are comprised of 26 different countries, 26 different ways of speaking Spanish with different meanings. So therefore, the need of meeting people where they are, asking them directly their understanding, asking them directly if they are being present, if they are processing the information presented, or if there is something there that is confusing to them. The language is powerful. Language is the beginning of the process of establishing equitable access to care. The multiple studies reviewed consistently indicated the need to increase early diagnosis tests and detailed assessments with healthcare providers, including the patients and their support systems input, thus igniting a proactive approach to addressing the disease. We have here that the best treatment is prevention and early detection. Walking on this path of becoming informed and gaining knowledge about ADRD and the impact in the Latinx population is an invitation to reflect about people assisting others while facing their own limitations, scholarly levels, cognitive mental health, and other conditions that could diminish their ability to embrace the challenge of caring for someone that faces a progressive and debilitating disease. In other words, caring for a patient that will no longer get better. Therefore, the relevance of addressing the disease and everything that involves from a holistic approach that places patients and their support system at the center of the programs and interventions, by including the perspectives and recommendations, thus facilitating the caring conditions from a place of respect and understanding. Alzheimer's disease and other related dementias are reaching epidemic proportions with higher rates of diagnosis within the minoritized populations. The Latinx caregivers of ADRD patients face multiple caring demands that change as the disease progresses. Scholars indicate that understanding the disease and all the details will help caregivers adapt to the changes and advocate for the support they and the patients need. However, other studies indicate that the initial experience of receiving the diagnosis was not followed by psychoeducation about the disease. Subsequently, patients and caregivers were left confused with a more than scary and demanding diagnosis. The studies also highlighted that consumers are not properly guided through referrals to services that could increase their abilities to respond to the care demands from a place of awareness. It was also noted that caregivers are frequently unsure where to start the formal process of caring. Although there are available services, they observe a universal approach that neglects the exclusive characteristics of the Latin population. Among the frequent recommendations expressed by consumers is that the caregivers will benefit from getting a space to understand the disease and receive the psychoeducation needed to aid in normalizing the feelings associated with caring. They must be connected to a system of care that intentionally honors them as their loved ones' memory keepers. This podcast aims to raise awareness among providers, therefore inviting them to leverage the power from their leadership positions, works towards addressing policies and procedures that discriminate against disadvantaged populations. Thus, anti-racist practices can ensure social justice for the Latinx population. There is so much to unpack on this first episode, and there is definitely so much to learn and absorb in the following episodes. There has been a significant amount of information about ADRD, what it entails, and the ways it's more prominent among the Latinx and other minoritized population. The information is intended to support the audience understanding of the urgency of addressing the disparities that drift apart patients and their caregivers from effective support and services. The lack of acknowledgement appears to be one of the obstacles that hinders proactive and informed advocacy, leading to ensure patients and the caregivers' well-being. To recap this episode, the podcast series is free of cost because it's gonna be advertised in the YouTube platform and it doesn't require any subscription. During the 10 episodes, information about Latinx caregivers of ADRD patients will be addressed to create positive changes for a population facing multiple societal challenges. As the largest minority in the United States, the Latin population is in urgent need of policy and regulation changes within the healthcare system. Thus, their well-being can be increased. Their voices are waiting to be elevated, and their participation in program development is required considering their uniqueness. Completing the series, and this is a message for all the people that is interested on continuing the series of the Memory Keepers. Completing the series will grant interest providers, social workers, and qualified consumers a certificate of cultural awareness among the Latinx caregivers of ADRD patients. I am highly motivated to continue spreading knowledge and kindness. In this first episode, we'll dig into the Latinx population, the incidences of the disease and the impact of the population, what the research highlights, and the following steps to create positive changes that ensure social justice and well-being for this group of people. The next episode will discuss the Latinx population, the caregivers, and cultural differences among Latinx, intersecting factors that determine access or not to services. This concludes today's episode of the podcast Memory Keepers. My name is Sylvia Bernasa, and I am your host for the series. To all of you who listened to today's episode, big thank you. Your time and interest are highly valued and appreciated. Remember that at the end of the series, you can complete a questionnaire as a requirement to obtain a certificate of completion. To access, please contact sylvia.bernasa2@siemens.edu.